Welcome again to the medical student whom join us in the series of lecture of cardiovascular disease. Our subject today is the second lecture in the common cardiac arrhythmia. Just to remind you, the first lecture it was about the cardiac arrhythmia. We discussed the normal sinus rhythm, and we said it's formed in the depolarization in the SA node and spread into the interatrial conducting system, then AV node down to bundle of his to the both ventricle. And we said is the normal sinus rhythm is the rate between 60 to 100, and it's a regular RR wave equidistance, and every QRS complex preceded by P wave and normal PR interval, which is 3 to 5 small squares, and normal QRS complex. And we said at that time any deviation from this normal sinus rhythm is called dysrhythmia. And also we discussed the main mechanism of dysrhythmia, and said it is re-entered the most common, especially in the tachycardia, and the automaticity either accelerated or decelerated, and the triggered mechanism. The fourth is the rare is the parasystole. And also we talk about the causes. We said it could be physiological, pathological, valvular heart disease, ischemic heart disease, heart failure, cardiomyopathy, myocarditis, pericarditis, and so on. We discuss all common causes of common cardiac arrhythmias. And also a few words about how to diagnose. We said it's originally how to present it. Usually presented most of them asymptomatic, what depends really underlying cardiac disease, how frequent these arrhythmia, how serious is this arrhythmia. Usually asymptomatic, could be syncope, could be pre-syncope, could be palpitation in the second most common, could be heart failure, and it could be fatigue, and even, as we said, second cardiac death. How to diagnose? We said it's the resting ECG, usually not pick up the arrhythmia, because most of arrhythmia are intermittent and infrequent. We do ambulatory Holter monitoring in 24 hours, and we will find this infrequent arrhythmias. In infrequent, we do loop, and we do implanted record, and lastly, we do electrophysiological study, not for diagnosis, for management, like catheter ablations, or to know the origins of arrhythmias and mechanism of arrhythmias, and also that the most probable class of a drug working in this arrhythmia. Today lecture it will continue, and also in the first lecture take that the sinus tachycardia, sinus bradycardia, and sinus arrhythmia. Today lecture it will continue these arrhythmia. First of all is the premature atrial contractions in atrial arrhythmia. Our subject today is atrial arrhythmias. So rate are normal or accelerated. P wave usually have a different morphology than the sinus P wave, because it's a premature start in the atria, because they originate from ectopic pacemaker in the atria. QRS complex normal, conduction normal. However, the ectopic beats maybe have different PR interval. Rhythm of premature atrial contractions occur earlier in the cycle, and they usually don't have a complete compensatory pause. We will discuss this when take an example what mean by complete, compensatory, incomplete, half, not half complete. Premature atrial contraction occur normally in non-disease heart. However, if they occur frequently, they may lead to the more serious atrial dysrhythmia. They can also result from congestive heart failure, ischemia, chronic obstructive pulmonary disease. This is what called the P-wave QRS complex. P-wave QRS complex. This we didn't expect a beat there, so it has come earlier in cardiac cycle. The PR interval little bit different, and P wave in this beats and in this beat too, it's different from that sinus. Look it. QRS complex usually normal. It means the impulse down the AV nodes is normal conductive system, while the defect in atria. And what mean by the not complete compensatory period. It means that if we calculate this interval between two beats and this ectopic, it's not like the double RR waves there. If we find RR wave, the distance, this distance not the double, not quite, and I mean double this interval. So it will be in the premature ventricular contraction. Will we find RR interval by times equal this distances? This is complete. This is in atrial, it's not complete. So this is if we do a report, this is a premature atrial contractions. Premature atrial contractions. Could be one, could be more than, could be multimorphic, could be bigeminy, and so on. But this is enough for you. Paroxysmal atrial tachycardia, what called PAT. Rate atrial 160 to 250. May conduct to the ventricles, maybe 1 to 1. I mean every impulse passes to ventricle, or maybe block. 2 impulse to 1, or 3 to 1, or 4 to 1. Into the presence of the block in AV nodes. Not every impulse passes. If it is every impulse, an atria pass to the ventricle, so 1 to 1. P-wave morphology usually varies from sinus because it is arising from atria. QRS complex usually normal unless associated with apparent ventricular conduction. That's why it's called PAT with block or PALT with abnormal conduction. Conduction PR interval depends on the states of AV conductions or conduction, tissue and atrial rate, may be normal, abnormal, or non-measurable, I mean P and PR interval. PAT may occur in normal as well as disease heart. It is common complication of full Parkinson-White syndrome. This rhythm is often transient and doesn't require treatment. However, it can be terminated with vagal maneuver. The digoxin antiarrhythmic drugs cardioversion may be used, but it is rarely. So it is the rate there, usually triggered by ectopic. And the rate there about 160, and it seems to be regular. The P wave is not apparent. Its morphology, it may be in QRS complex preceded or the after QR or not seen. And this is by the supposed vagal maneuver is converted to the sinus rhythm. This is called paroxysmal atrial tachycardia, PAT. While MAT is the multifocal atrial tachycardia. It's autonomic atrial rhythm from various different foci, not like that in one focus. Usually atrial ectopic there and lead to this rhythm. Seen in hypoxia, usually MAT is the chronic obstructive airway disease, atrial stretch, and local metabolic imbalance. 3 or more types of P wave in multiple. So it is multiple atrial tachycardia, so it is multiple shape of P wave. The rate more than 100. The digoxin worsen it, so treat with oxygen, slow channel blocker like verapamil or diltiazem, calcium channel blocker. So if we look to the rate is about 170, it seems to be irregular, and the P wave, if you look there, abnormal, and there the P wave, it's after QRS complex is the P wave there, and some P wave inverted, and some P wave, different types of P wave. Look to this is the abnormal P wave, and this is abnormal P wave. P are different from different, and the P wave after QRS complex, this is a P wave, and this is a P wave. So this is what called the MAT, multifocal atrial tachycardia. Atrial tachycardia. Now come to the atrial fibrillation is the most common rhythm in the disease heart. The most common rhythm in the admitted patient with the heart disease. The rate is atrial rate usually between 400 to the 65. But not all this atrial rate passes to the ventricle. P wave not present. You will not see because of that it's not effectively depolarized in the left atrium. It's a wavy baseline seen instead of the P wave. This wavy line, if it is a coarse, so it is coarse atrial fibrillation. It's fine, called fine atrial fibrillation. QRS complex normal, this means that the impulse below IV nodes is in a normal conductive mechanism. Variable IV conduction, we say it's not this rate 400, it will pass to the ventricle. So there is conduction different variable degree. If untreated, the ventricle response usually rapid, so it's called rapid atrial fibrillation more than 100. If it's less, it will be the slow atrial fibrillation. Rhythm irregularly irregular. We will see irregularly irregular. This is the hallmark of this dysarrhythmia. Atrial fibrillation may occur paroxysmally, it means in paroxysm, but it's often become chronic or permanent. It's usually associated with chronic obstructive airway disease, congestive heart failure, cardiomyopathy, or other thyrotoxicosis, and myocarditis, pericarditis, hypertension, and so on. A lot of causes of the atrial fibrillation. Treatments include rate control and rhythm control. If the rate high, first, all cases it needs rate control. Not all cases need rhythm control. It means this is the rate if it's 140, 150 to control it. If a rhythm to change into the sinus rhythm. The rhythm control, rate control usually by medicine, drugs, while rhythm control could be drugs or cardioversion. Digoxin to slow IV node conduction, so it is rate control. Cardioversion may also necessary to terminate this rhythm, especially if the patient hemodynamically unstable. And anticoagulation necessary in the atrial fibrillation because there is a risk of a thromboembolism. If we looked at irregularities, it's, if you remember, not like sinus arrhythmia. There is no P wave, only undulating baseline. This undulation baseline, so fine, it's not coarse. Sometimes we find it's a coarse like that. The rate, if we try to calculate, as you remember, we take 15 square, big square, 1, 2, 3 until 15, and times the number of RR by 20. If we take 30 and time the number of RRs by the 10, this is if it's irregular. If regular, you know how to calculate cardiac rhythm from the second year. So this is atrial fibrillation. Come to this sample. It's irregularities. No fashion for this irregularities. So there is no P wave. This is undulating. And this is sometimes coarse, but it is a fine. There is no P wave at all. QRS complex looks normal, and the rate here is the about, if we take 15 square time by 20 to 5, this is the one called atrial fibrillation. So atrial fibrillation, one of the types of atrial arrhythmia, a condition in which electrical signal come from atria at the very fast, as we said, 400 to 600, and erratic. What means erratic is in a chaos, is a not irregular, that the ventricle contract in an irregular manner because of the erratic signal coming from the atria. Fine, an atrial fibrillation, fine oscillation of baseline, so-called F wave, small F wave, and no P wave. Common causes include coronary artery disease, valvular heart disease, hypertension, hyperthyroidism, cardiomyopathy, congenital heart disease, and other causes. In some patients, no cause can be found. This is called lone atrial fibrillation. In some textbooks, said 10% or something like that. Come again to this. It's a slow, really, the rate, if we calculate 15 square and times less than 100, but this undulations. Sometimes it course like that. Other times it's fine, the baseline. This is what's called small F wave. And this is atrial fibrillation. Atrial fibrillation caused by numerous waves of depolarization. spreading through the atria in a chaos in the erratic fashion, leading to absence of coordination of atrial contraction. Classified as clinically is recurrent when atrial fibrillation occur on 2 or more occasions and terminated spontaneously. This is recurrent. Some paroxysmal episode that gradually last less than or equals 7 days, mostly less than 24 hours. If it's persistent, what means persistent atrial fibrillation lasts equal or more than 7 days. What called permanent, so recurrent paroxysmal persistent permanent atrial fibrillation or AF, paroxysmal or persistent AF with a failure to cardiovert or not attempted cardioversions. The treatment and diagnosis of atrial fibrillation, so absence of P wave, irregular, and ventricular response looked, it depends on the conduction, this atrial fibrillation. Rate control in all cases. Rhythm control, not all cases. Beta blocker, calcium channel blocker, digoxin, amiodarone, first-class anti-arrhythmic drugs. If we come IV, we can give even digoxin IV in rapid IV infusion. Oral propafenols or the flecainide, beware about pro-arrhythmic effect of this medication. Low voltage DC sometimes high voltage. If the patient hemodynamically unstable, shortness of breath, heart failure, unconscious, and the hypotension, sometimes we do cardioversion per atrial. The dose usually high, more than 100 joules. Causes, we will summarize the causes of atrial fibrillation. There are multiple causes of atrial fibrillation, include, as we said, coronary heart disease, hypertension, valvular heart disease, mitral stenosis, regurgitation, acute infection, example, pneumonia, electrolyte disturbance, hypokalemia, hypomagnesemia, and thyrotoxicosis. Look to that, the EC, this is coarse baseline, not the fine as we said, but really irregularities, there is no P wave, QRS complex to be within normal due to that the passes of, the impulse down the AV node is normally. So irregularities, there is no P wave, absence of isoelectric light. Variable ventricular rate due to the conductions, QRS usually less than 120 milliseconds, unless there is a pre-excitation or block or accessory pathway. Fibrillary wave or small F wave may be presented and can be either as well amplitude less than 0.5 ml confined and more than 0.5, small square, more than a small square, it is a coarse amplitude more than 0.5 ml. Fibrillary wave may mimic P wave, leading to misdiagnosis, especially in the lead V1. Because of the atrial fibrillation, the risk of a thromboembolism is high. As we discussed, atrial fibrillation in the valvular heart disease, always use oral anticoagulation. While in atrial fibrillation in non-valvular heart disease, we use the way of assessment the risk. If the risk high, give oral anticoagulation. Otherwise, less. So there is two ways, by CHAD S2 or CHAD VASC. This is score, give you a score and a clinical prediction rule, how the risk of the thromboembolism, and give the proper treatment. To estimating the risk of stroke in patients with a non-rheumatic atrial fibrillation, a common and serious heart arrhythmia associated with thromboembolism. As we said, the commonest arrhythmia in the inpatient, the commonest arrhythmia in the heart disease patient, and the serious because of thromboembolism. This is the chart. The chart, it means congestive heart failure, hypertension, age more than 65, diabetes, and stroke transient risk. Everyone have 1 point except stroke is 2 points. So it is a 6 point. But the chart VASC is the other vascular disease and the age also other groups. But this is the chart VASC. Look, congestive heart failure 1, hypertension, and age have 0.2 score, but this is more than 70. Age that means 65, 74, 1. If we calculate, this is a 6 point. If they calculate this 10 point, but usually 9 score because of age is the here and this is range. At least one of these it will fill. So it is this 9 score range and this is 6 score range. What mean by that? If the patient have a 0 score in both of them, in either of them, so usually use aspirin. So the risk is very low of thromboembolism. If the score 1 and the aspirin and consider oral anticoagulation, it depends. More than 2, consider oral anticoagulation with the INR targeted to 2 to 3 INR, the range of to prevent thromboembolism, and caution for the risk of bleeding. Look, this is the percent and risk of thromboembolism. So Y is 0, we can use aspirin or clopidogrel or no therapy. In both them, CHAD and CHAD-VASC even 0. But if one, you have aspirin or consider oral anticoagulation and also other risk. The same as for CHAD-VASC. So CHAD-2, CHAD-S2 or CHAD-VASC score for the stroke risk assessment in atrial fibrillation. So it's cardiac rhythm with potential to cause thromboembolism. Studies suggested that atrial fibrillation increased the risk of stroke 5-fold. So 5-fold from the non-atrial fibrillation risk of the stroke, or transient ischemic attack. Thus, it is important to determine which patient with atrial fibrillation according to the CHAD-S2 or CHAD-VASC2. It's important to determine which patient with atrial fibrillation may benefit from oral anticoagulation and possibly aspirin therapy to reduce the risk of stroke. Oral anticoagulation used in this setting include the following medication for stroke prevention with atrial fibrillation, and this is the standard treatment, warfarin, but usually warfarin is a nasty medicine with a lot of complication and with a bleeding tendency. And the ratio of INR between 2 to 3 is targeted. International normalized ratio must be 2 to 3 and follow at every 2-3 weeks. Some patients every 3 weeks do INR. While the Excipan group, this is Excipan, oral anticoagulation, Dabactran and other Excipan group we can use instead of warfarin. It's better really than warfarin, not to follow by INR. Risk of bleeding nearly similar, but it is really more expensive. This is always come in questions for the students. Usually, please, condition associated with atrial fibrillation that increase in size and pressure in left atrium. The cause, the mechanism is the size enlargement, like mitral valve disease, Epstein anomaly, or pressure like pulmonary hypertension. For systemic hypertension pressure, mitral tricuspid valve is the pressure and volume. Congestive heart failure volume, acute myocardial infarction, congestive heart failure, which causes atrial abnormality, ASD, Epstein anomaly, pulmonary hypertension due to the pressure overload. This causes atrial fibrillation but due to the atrial size, stretch, or pressure. While atrial fibrillation metabolic or drug effect on atrial impulse formation, like thyrotoxicosis, drug toxicity, sympathomimetic, theophilia, alcohol, what called binge drinking, holiday heart syndrome, hypoxia, while the atrial fibrillation during infiltration or inflammation, pericarditis, postcardia, surgery, and pneumonia or tumor invasion. So much, enough for the atrial fibrillation. Now come to the atrial flutter. The atrial flutter is a type of supraventricular tachycardia. Like sinus tachycardia is supraventricular. Like atrial paroxysmal atrial tachycardia multifocal atrial tachycardia, atrial fibrillation. All of this is the supraventricular, caused by re-entry circuit with the right atrium now in anti-clockwise fashion. We will see it in diagram. The length of re-entry circles correspond to the size of right atrium, how big is, resulting in a fairly predictable atrial rate of around 300 to the about range 200 to 400. So ventricular rate is determined by AV block. If it's all pass, so it's very high. It means 1 to 1. And another conduction ratio degree of AV block. The commonest we will see it ratio 2 to 1. Every 2 impulse in the atrium, in the right atrium, due to the re-entry, 1 it passed to the ventricle, resulting in a ratio, if it's 300 is 150. As a 400 result in a 200 beat per minute ventricular rate. And so, higher degree of AV block can occur, usually due to the medication or underlying heart disease, resulting in a lower rate of ventricular conduction. Example 3 to 1 and 4 to 1. If it's 300, 3 to 100. If it's, 300 atrial rate, here is a 75, and so on. Atrial flutter with one-to-one conduction can occur due to the sympathetic stimulation or in the presence of accessory pathway, like Wolff-Parkinson-White syndrome. It's a serious with hemodynamically, especially if the AV nodal blocking agent are administered in patients with the Wolff-Parkinson-White syndrome administered wrongly. Atrial flutter one-to-one conduction is associated severe hemodynamic instability and progression to the ventricular fibrillation if it's not terminated. And this is what called right atrium big. How big is right atrium compared with left atrium? And anti-clockwise of re-entry mechanism and passes down to give, as we said, the AV node block. Maybe 1 to 1, this is the rare and more serious. 2 to 1, the commonest. Sometimes alternating. 2 to 1, 3 to 1, or 4 to 1 in the same record too. ECG feature, general feature usually narrow complex tachycardia. It means QRS complex is narrow. Regular atrial activity is not like that of atrial fibrillation, irregularity. The rate of atrium more than 300. The rate of ventricle, as we said, depends on the AV block degree. Flutter waves, we said in the small F wave is the fibrillation wave. This capital F wave, so sawtooth pattern, best seen in the lead 2, 3 AVF, and be more easily if the spotted by turning upside down the ECG. Flutter wave in V1 may be resemble P wave. Remember this. Look to the lead 2, 3 AVF. We see it's inverted and it is sawtooth appearance. And in the V1 like the P wave, sometimes confused with P wave. Loss of isoelectric baseline like atrial fibrillation, but here is the course. Fixed AV block. As we said, ventricular rate is a fraction of atrial rate. Example, 2 to 1, if it's 300, so 150. 3 to 1, 100. 4 to 1 is 7. 1 to 1 is the 300. This is the rare and the more serious. Variable AV block in the same record. The ventricular response is irregular and may be mimic atrial fibrillation. On closer inspection, there may be a pattern of alternating 2 to 1, 3 to 1, or 4 to 1 conduction ratio in the same ECG record. Look at this example, please. This is one P wave, 1 P wave, 1 V. So this is a 3 to 1, 3 to 1. If we look at like sawtooth appearance, this is 1 P wave, this 1 P wave, 1 P wave, 3, every QRS. Narrow QRS normal because the conduction passes from the below AV node down normally, but this is what called capital F sawtooth or flutter wave, and this is 3 to 1. And if we look this is easily 4 to 1. 1, 2, 3, 4 to 1. This is 2 to 1. So it is called atrial flutter is caused by re-entrance circuit, as we call the wall of right atrium. Sawtooth flutter wave at rate of atrial rate more than 300. Flutter wave have constant amplitude duration and morphology. Constant, not like atrial fibrillation, sometimes fine or sometimes cold. This is amplitude equal. That's why sawtooth appearance. There is usually 2 to 1 or 4 to 1 like in this record at the AV, resulting in a ventricular rate 150 or the 75. If we look to the atrial 2 to 1 block and the F wave, if we look, as we said in the lead V1, look to it like P wave here, as we said. If we look to the lead 2, lead 3, ABF, it is sawtooth appearance. This is the 3 2 to 1 block, which is normal to see that. The most common I see, most common. And this is 4 to 1 block, 1, 2, 3, 4. If we look to the lead 1, as we said, like P wave. If we look to the, don't forget lead 2, lead 3, ABF, it is sawtooth appearance and coarse and similar. And QRS complex, this is 4 to 1 atrial flutter. How to diagnose? Usually by ECG and treatment. Unmasking of flutter wave with adenosine. Adenosine, if we give in the, as we discussed later, in the supraventricular tachycardia or carotid massage, here not masking if we give adenosine sometimes as a test. As we said, it's maybe especially if 1 to 1, 2 to 1 if rapid, so it's like the supraventricular tachycardia. To differentiate, sometimes give adenosine and adenosine is not converted. Ventricular rate control can be difficult. An AV nodal block prevent one-to-one conduction. A class 1 antiarrhythmic rapid infusion have a paddle ready, DC ready sometimes, because of, sometimes propagated to the serious rhythm. Rapid pacing sometimes, or slow voltage DC cardio, low dose DC is effective. Anticoagulation, please, as per atrial fibrillation, because of similarity and most commonly degraded down to the atrial fibrillation. It changed to the atrial fibrillation. Sometimes both of them in one ECG called the flutter fibrillation. We will see example of this in the. This is the. Please do report of this your homework in the next week. Do report of this lead to strip and look and to P wave, QRS, rate, rhythm, and so give our your comment. Ramadan Kareem على الجميع. See you soon later. See you soon. And Ramadan Kareem على الجميع. Bye.